Hello, Nav Cavale here, plastic surgeon. Welcome to the Real Clinic podcast, sponsored by 42 South Films. This is where we take a behind-the-scenes look at the surgery industry, get to meet key players in the business, learn about setting up a clinic such as Real, and meet some of the best surgeons around. Welcome to another episode of the Real Clinic podcast. Today, I'm really pleased to say that we're joined by our very first power couple, Elizabeth Hawkes and James Neffendorf. Welcome both. I'm hoping we will talk about how not only are you guys a married couple doing the same subspecialty in medicine, but also a bit about how training, education is changing in ophthalmology and a bit of plastics with a bit of luck in comparing the two, and how we can make things better for trainees coming through the system, because it is getting tougher, it is getting difficult to retain trainees in our specialties. But let's see, maybe you guys have got ideas as to how we can do things better. So yes, welcome. Thank you very much for joining us.
Thanks, Nat.
So I don't know what I'll probably do, if it's all right. I mean, in my usual rambling fashion, is out of chivalry and courtesy, if I just start off with you, Elizabeth. Why don't you just start off? Tell us who you are, where have you come from, give us your background, going back as far as you want to, and then I'll come on to you, James.
My name's Elizabeth Hawkes. As you said, I'm a consultant ophthalmologist and oculoplastic surgeon. So I specialise in blepharoplasty surgery now. I went to university at Imperial College in London. And then I did my ophthalmic specialist training around the UK, so South London, Kent, Surrey, Sussex, Oxford. As you know, we move around a lot in surgery. Then I became an NHS consultant in 2018. That was in Royal Berkshire, the Royal Berkshire Hospital, and I was running the eye casualty department for the region of Berkshire, and doing oculoplastics and intraocular surgery. Then I left, and I've been in full-time private practice since 2020. And that's me.
And you're now sort of central London practice, aren't you?
So now I'm based in central London. I'm based in Chelsea, and that's my base at the moment.
Cool.
And I took over the practice of Professor Richard Collin, who's a very well-known oculoplastic surgeon, and I see all his patients there.
Thank you. Same question to you. This is going to be easy.
So I'm James Neffendorf. I'm a consultant ophthalmologist as well, but slightly different to Elizabeth. I'm a retinal surgeon, so that's work at the back of the eye. My background is that I grew up in Northumberland, so up near the Scottish border. And then following that, I went to university at Cambridge, did my undergrad at Pembroke College. And then, as you know, I went to UCL.
Much better university.
And stayed in London for a couple of years at that point. And then I did all of my eye surgery training in Oxford. And after fellowships in London at St Thomas's, I've been a consultant at King's with you for the last 3 years.
Cool.
So it's going very well.
So James, if I can then ask you, why do you do what you do? How come back of the eye, and what made you end up in that part of the body, as it were?
Yeah, it's a really good question. I think my very first experience of ophthalmology was when I was at school, and I did some work experience with an ophthalmologist. Right. And of course, at that stage, I didn't really have any idea what I wanted to do, but I found it very interesting. And
are you from a family of doctors or ophthalmologists or anything like that?
No, I'm not. I just happened to be at a school where there were a lot of parents who were doctors, and a family friend was an ophthalmologist. So at that time, that's what I did.
Elizabeth are from a family of an eye surgeon, is that right?
Yeah, my mother's an eye surgeon. My dad's a neurologist.
Okay, cool. Sorry,
so
anyway, I
come very much from a business family rather than a medical family. So that was my first exposure with ophthalmology, and then I found it really interesting and started to explore it a bit more. And at university, I always decided to, if I had a choice, a module or research project, I decided to do something in eyes because it's what I knew. And I think the more I understood about it and got into it, the more I thought it would be a good career choice. Okay. And then why the retina? Well, the retina is arguably the most important part of the eye. I mean, you probably disagree with that, but I find the surgery very interesting. We make a big difference to people's sight, and I also do a lot of complex cataract work as well. So, I have a nice wide portfolio of interest.
Nice. And then same sort of, again, coming to you, how come your oculoplastics, or what was your evolution to end up doing that?
Well, I mean, ophthalmology obviously came up at the dinner table a lot when I was growing up. So I had an interest
We're going to come
before.
on to that later, actually, about your dinner table.
So I did have an interest before medical school. As a medical student, I knew I always wanted to be a surgeon. And then, I rotated through the jobs of cardiothoracics, vascular, but always I kept going back to eyes. I was always really impressed by the very precise, delicate nature of the surgery. Very rewarding surgery, and most patients are highly satisfied after the procedure. So I knew I wanted to be an eye surgeon. And then actually the very first operation I did in my first year as an ophthalmologist was a blepharoplasty combined with a ptosis. And I remember just thinking, wow, this is the coolest operation. We've raised the height of someone's lid. We've made the lid look aesthetically better. And also, all throughout medical school, I used to do all my friends' eye makeup before our balls or our bops. We used to line up and I'd do their eye makeup. So I've always been interested in this sort of aesthetic aspect of the eye. And that's, I think, how I found oculoplastics, and I'm happy I did.
Because I've got similar-ish story with eyes, because my BSc, my intercalated BSc at UCL was in ophthalmology, actually. I ended up in the Institute of Ophthalmology, which was in Judd Street back in the day, and I was in a basement looking at slices of ferrets' brains, because no one cares about ferrets, but they've got binocular vision, and so it's not cats or monkeys, and so I almost became an ophthalmologist, but I kind of decided I quite liked the head to toe variety, so that's, I guess, what anyway. But I almost was an eye surgeon, but it never quite came about. But so, what kind of things do you currently, Elizabeth, what's your favorite operation now, having gone through that sort of growth or evolution? You're specializing in blepharoplasty, but is there kind of, to get into the, I don't know, different types of blepharoplasty, or what do you really like doing?
Well, I definitely like blepharoplasty surgery, but I suppose within blepharoplasty, I think I love the lower lids. Recently, I've had some really tricky lower lid blepharoplasties, patients with really big eye bags. And it's so satisfying reducing the bags, repositioning them, and then seeing their after result, even on the table. So I think that probably, I like all parts of blepharoplasty, but that's probably my favorite one at the moment.
Because I kind of, as a plastic surgeon, I'm always doubtful that am I doing blepharoplasty properly, and I'm never entirely sure. I don't really do ptosis surgery, for example, but I will do a standard upper bleph and maybe not remove a bit of fat. I don't often, maybe remove a bit of muscle, but again, not very often. And then the lower lid, I'm always a little bit scared of, but tend to do that as part of a general anesthetic, which I'm guessing is the same as you. Is that right? So do you do upper lids if you can under local, lower lids not under local?
Usually I prefer to do lower lids under a general anaesthetic. It's more comfortable for me, more comfortable for the patient. Upper lids you can do under local, but I'd always advise patients to have it under with some light sedation, at least with anaesthetist present. It's just more comfortable.
I think, I agree. And then just bringing it sort of onto more about the real clinic here. I know that you've been training with me as to how to use our new laser. How do you see that sort of stuff fitting in with your practice? Because you're yet to really, come and work here, and I know you've got a busy practice elsewhere, but I'm hoping to suck you in with the laser. So tell me how that might work.
So that's really interesting. So what I find with a lot of my patients is they usually find me because they're concerned about their eyes. They feel they look tired all the time. They want eye rejuvenation. So we start with either a surgical solution or even some non-surgical treatments. But then once my patients are happy with their eyes, they start looking at the rest of their face. And they think, oh, actually, is there anything else I can do? And many of my patients stay with me for that reason long term. We do treatments like skin boosters, dermal fillers.
And you're offering this yourself, is that right?
Nucleotides. I do it myself. I love the non-surgical side of my practice. I really enjoy it. My practice is a real mix. 50% of the week I'm doing surgery, 50% I'm doing non-surgical. So the way I'd like to incorporate laser is just skin rejuvenation. It's just the next step up for skin boosters, rejuvenating the skin, improving texture, helping with fine lines and pigmentation. And I think many of my patients have already expressed an interest to have the laser, and I'm looking forward to doing it.
Great. And then I will come to you, I promise, James.
You keep going.
The bit that I don't understand about the laser is, for example, I know eye surgeons use it to treat dry eye. I don't understand how that can possibly work, but because I thought it was something, you're lasering something maybe even in the eye, but no, it's not. You're actually lasering around it, aren't you? Tell me about that.
So laser is a really interesting one. So actually, us as ophthalmologists, we have to do an exam in refraction and lasers. So we're really comfortable using lasers inside the eye. And there's lots of different types, and James uses lots of laser in his surgery as well for the back of the eye. But specifically how this laser is using light, intense pulse light, that's the laser.
BBL side of the Cyton, isn't it?
The BBL side of the Cyton, and how it works. So this type of laser works for broken blood vessels or telangiectasia, so the redness around the skin. So it works really well on the skin. And actually blepharitis, which is a chronic inflammatory condition of the eyelid, one of the hallmark features are these broken blood vessels on the lid margin, telangiectasia. So this was actually pioneered by an ophthalmologist in America.
Right.
And what he noticed in treating patients with the light for rosacea, that actually their symptoms of blepharitis got better. So the way you treat it for dry eye, so technology's moved on a lot now, but essentially you're treating all the way under the cheek and up to underneath the lid to try and target the telangiectasia on the lid margin. Obviously, you're limited in terms of how close you can actually get, because obviously in between eyelids and eyelid.
You would be getting closer than say somebody else that's delivering BBL to the lower eyelids.
Absolutely.
Because you're obviously trained and brave enough and able to get that close without doing damage. So that's another reason why you should go to a proper clinic. That's the advert over and done with. So coming on to you, James. So again, your retinal stuff, the VR stuff is a mystery, but again, you fire lasers, but at the back of the eye, through the eye. So tell me what kind of stuff are you dealing with? Give us a little overview of what you're up to and what your favorite things to do are.
Yeah, no, it's a great question. So in VR surgery, we deal with mainly diseases of the vitreous and the retina, as the name suggests. And the things that people will have heard of are retinal detachments, maybe macular holes. I deal quite a lot with trauma patients. So, people who may have had an issue where they've had their eye hit and they have damage to some of the intraocular structures, because often that manifests in problems towards the back of the eye. So you need a VR surgeon. And actually, out of all the ophthalmologists, there aren't many ophthalmologists who are trained in VR surgery. So in terms of favorite operation, I do enjoy, taking on complex cataracts, but I think actually when you do surgery at the macula, which is the central part of the retina, we you get to peel very thin layers. So we use micro forceps, and we're peeling layers that are literally microns in thickness. And the challenges are so different. Elizabeth's got the challenge of having to get that aesthetic perfection, whereas no patient can ever look at their macula. We can show them a scan, but they can't really appreciate what that really means. And so for us, it's all about functional outcome and making that patient see better. And we know that if you do careful surgery at the macula, you can make a massive difference to somebody's vision. And actually the success rates can be up in the 90% for people with macular problems.
I think restoring sight or improving sight, that was one of the draws for me for ophthalmology back in the day. Thank you.
So that's interesting. From you mentioned the lasers, obviously very different types of laser. We do a lot of retinal laser for patients with diabetes. There are other conditions when if someone gets a retinal tear, often people get floaters. You probably know people who've had floaters in their eyes. And that's one of the telltale signs that you might have a problem on your retina. So if you have a floater, you need to get that checked out, basically. Often it's benign, but it can be quite serious. So we do a lot of lasers and we're comfortable firing them through the eye.
And so just to kind of bring it together, I won't get too much into the details of your individual specialties, just because this is more of a clinic podcast. But so if we now sort of talk of the two of you, as a couple, you're married, you have kids. How give me an idea of how, I don't know, the Neffendorf Hawks household. How does that work? What's the conversation like when you get home this evening? Is it just eyes, or is it nothing to do with eyes? How does that work?
Shall I take it? Well, maybe there's two different versions.
It'd be interesting. Go on. First, James. So,
we're both super busy. I think that's the first thing to say. And we whilst we work together quite a bit, which we can come on to, we also have quite separate practices. My private practice is very different to Elizabeth's. We cross over a bit. I think, it can be stressful at times, eye surgery, and I think it does help a lot to bounce off, thoughts and ideas from someone who understands it, but we do try and not talk about it all the time, obviously. And because we run a business, we also have that element of things, which is completely specialty independent. And I think overall, we like to talk about eyes, but it's sort of an interesting element of it. And because we're doing slightly different things, it does give a bit of variety. And then we have a son, as you mentioned, called Maximilian, and he obviously takes a lot of our combined time. And then it's just combining the diaries, because we can't always both be in at the same time, and but one of us has to be in, and so it's well, I think it works quite well, really.
And how does the work side of things work? I mean, you don't have to tell me about the domestic side at all. It's none of my business. But work-wise, are you referring to each other professionally? Is that a thing that you do, or do you deliberately not do that?
In general, our patients are quite different patients. Liz has a group of patients who want to appear better. And actually, I would say we more commonly get those patients' relatives coming to me. So, I have a slightly older cohort. So you might have
we see that here in the clinic. I mean, because you
do
a lot of,
don't you?
You're doing a lot of work here already with us. And I can definitely tell the difference between the ophthalmology patients and the plastics patients.
Exactly.
So, and that's really a sort of the way it works, I think. We have had a couple of patients where we've both had to see them for, totally different eye issues. But that's, they would need to see an oculoplastic surgeon, so I would send them to Liz and vice versa. So it makes sense to cross refer.
Yeah, we definitely refer to each other. And I think that's one of the benefits. I think many of my patients choose me for blepharoplasty because they think, wow, she really knows the eye. And like I say to my patients, if there is a complication, very rare, blepharoplasty surgery on the whole is safe surgery. But if there is a complication with blepharoplasty, I'm an eye surgeon, so I can manage the complication through to the end. So naturally the conversation goes, like I said earlier, about, what else can I do to the rest of my face? They'll say, like I said, my relative has a cataract. Can you do it? Or my other friend has a problem with the eye, or I have a problem with the eye. And then I'll say, I know a great ophthalmologist. I do always say to the patients, he is my husband, for full disclosure. So it's really important for the patient to know that. He's my husband, but he's great. So most of the time they
and there's a little bit of crossover as well. I mean, one area of sort of research that we've crossed over a bit on is on dermal fillers. So Elizabeth has quite a few dermal fillers in her non-surgical practice, and there is a rare complication of vision loss from dermal fillers that I know is gaining a bit of traction in the aesthetics industry, and I'm it affects the retina. That's what they get. They get a retinal artery occlusion. So I'm currently leading a national steering group on this, which Liz is one of the members. And so we have there are some niche areas where we do cross over. Clearly, that's a rare complication, but I think overall, it is quite interesting to see how the two specialties do have a bit of overhang.
And just going back a little bit, did you guys meet through ophthalmology, or is that just a coincidence? How did that work? Did you train together? Or I don't know.
Well, we met as FY2s at St Mary's doing A&E. A&E, I was doing trauma. James was doing A&E, and we met at 4:00 in the morning. That's our story. I was scribe from the trauma point of view. I don't know why I was scribe. And James was actually hands-on at St. Mary's. It was when St. Mary's was becoming a major trauma centre, so it was really busy. And then actually we were friends the whole year. But how we became friends is we were like, that's the other one who wants to do ophthalmology, because not many people apply for ophthalmology. It is quite a niche to know quite early on if you actually want to go into the specialty. So we became friends because we were both applying for ophthalmology. We travelled up to our interviews together, and then
we were kind of competitors and enemies at the interview at first.
So were you contemporaries? Did you train together almost at the same level and end up?
Well, we ended up in different deaneries.
So we went out of choice together. I took a couple of years out to do a research degree. So then I slowed down, because of that. But then you finished just a bit earlier.
And did that work out okay because I've always thought of, and I might be totally wrong, but I see ophthalmology as being better than plastics for work-life balance.
I don't.
Was that was being ophthalmologist useful in that sense?
I think training, whatever specialty you do, is hard. You know, you still have to do the 24-hour on calls, 48-hour on calls.
Yeah.
Most of the time, you know, you move around hospitals a lot.
Yeah.
And I think for ophthalmology, for example, Kent, Surrey, Sussex, I was one of 5 trainees covering such a huge geographical area.
Yeah.
So for that reason, it was quite challenging because James was in the Oxford deanery.
Yeah.
And so we were constantly moving around. One year I was in Kent, Canterbury, and James was at the John Radcliffe in Oxford. So that was a huge distance. So I think that's a challenge, whatever specialty. But in the end, I actually did an interdeanery transfer for my last couple of years of training, and that worked really well.
And is it now going forwards to now that you're both consultants practicing and you have a son, is it useful? So if you imagined you were 2 plastic surgeons, would life be a nightmare compared to how it is now? Do you think? What do you reckon?
So what's the question?
So if you were being a couple of ophthalmology consultants working together as consultants, is the work-life balance good because you're ophthalmologists? Would it be worse if you were something else?
I mean, I think it's busy. You know, I think from a sort of most of the day and evenings we're busy. Now, some of that is we can work together on. Night work is pretty good in our specialty. We don't at this stage, but you know, going back to what you're saying about training, I think training is actually hard in ophthalmology, particularly at the start. There's a very steep learning curve. Because it's something totally different to the foundation years, and you've never done it. So I think there's a bit of a hump at that stage, and you're very much on your own as an ophthalmology trainee. But when you get, you know, as a consultant on call, for example, I would only really be needed for like a complex trauma repair or a really complex case because we've got fellows and you know, residents on site. So I think the work-life balance is good in terms of the actual clinical work.
Day job.
But of course, as you know, the day job's only a small fraction of the hard work that goes on beneath it.
Exactly. Yeah. And I was going to come on to the next thing, which is, you know, you guys, you've got your place now in central London, Great Titchfield Street.
So it's called the London Lauriston Clinic.
Okay. So tell us about that. I know take turns, whatever. Yeah.
So I'm deputy medical director there, and it's a new clinic that opened a few months ago. We've got, I think now up to about 35 clinicians with practicing privileges, and we're a clinic that is poly-specialty really. So it's ophthalmology, we've got various endocrinologists, obstetricians, gynecologists, cardiology, and we have a minor ops theatre. So we're really trying to cover and we have GPs. So we've got patients who are visiting their GP, but also all of the medical specialties in ophthalmology. We then operate elsewhere. And as you know, I do a lot of my surgery here. And I think that balance works quite well because, you know, different entrepreneurial ventures can work together rather than us all doing everything.
It's great the way that I get the feeling we complement each other really nicely. You know,
and we're not stepping on each other's toes. No. I think it's better to do something and do it well than try and do everything and do it less well.
And then do you work out of there at all or not yet?
I'm starting very soon. Yeah.
Cool.
Yeah, exactly. I'm really excited.
Yeah. No, it sounds. I'll come visit. Actually, I haven't seen it. It'd be great to come have a look.
Come to the opening day.
So what? So you know, we've kind of covered a whole load of, you know, you've trained as ophthalmologists. You've, you know, come together as a couple. You've got a family. You are working independently, slightly different but similar. What's the future? You know, what's next? So Elizabeth, tell us, you know, what do you want to do next? What's the next big venture, whatever?
Not sure. It's difficult to know. I'm really happy with my practice. I feel so lucky. I've got such a great group of patients. Lucky business is good. I have a healthy waiting list for surgery. Not too long, but not too short either. It's not you can have surgery tomorrow. So I'm pretty happy. I just hope to grow, keep getting good results, you know, doing a good job for the patients, really, from a professional point of view. And then outside, we're really happy with our son, Maximilian. And it's just really exciting, like seeing him grow or his new developmental milestones.
How old is he now?
He's 28 months.
Okay.
So just sort of
feels like such a long time ago.
How
an 18-year-old
choosing schools at the moment. That's the challenge.
And what about you? What do you see the future? What's the clinic called again?
The London Lauriston Clinic.
Is there going to be a...
I mean, I'd like to see that obviously flourish
Yeah.
and get bigger. And as part of that, obviously, my personal private practice,
Yeah.
you know...
Are you going to branch out to other locations, maybe?
I think it's always hard to say.
Yeah.
I think we want to do one location successfully first. And then we'll take it from there. But I have quite a varied portfolio. So I've obviously got my NHS job. I've got my private practice. I do quite a lot in medtech. So I work with some startups. I work with an accelerator. I'm part of a sort of angel investors group looking at, exciting new companies. So I and that's what I find really interesting, the variety. You know, I really like my clinical side of things, but I also really like...
Is that your main hobby then? Is that what you get up to, sort of extracurricular, as it were, the
Well, in terms of, you know, from a work point of view, you know, that would be my other sort of main side.
Okay. Looking back on your life, your training, your career, if you were going to go and talk to your, I don't know, the SHO in St Mary's A&E that was scribing, and you were looking at the one that was doing the hands-on in that trauma call or whatever, what advice would you give, or what would you tell them to do differently? What do you reckon about those?
My advice would be to just go for it. I feel that it's probably similar with plastic surgery training as well. Doing aesthetics or being open that you like cosmetic is always a little bit frowned upon. But you know, I'd say if you want to do it, go for it. But I'd also say get all the qualifications you can. So for example, in aesthetics anyway, a lot of FY2s are saying, I'm just going to go straight into aesthetics. I actually think it's so important to go on a training program, complete it to the end, get CCT, be on the specialist register, and then, you know, the world's your oyster.
I mean, actually, let's talk about that a little bit. That's a really good thing to touch upon, actually. So, you know, tell me about your thoughts on the current state of non-surgical aesthetics. Actually, I think that's something I'd be really interested to hear about from your point of view, because, you know, I've got my views. And they're probably very similar to yours, to be honest. So, what do you think we should do to stop some of the junior doctors going off? I mean, I know people who have done 6 months as an SHO in plastic surgery and are now setting up as aesthetics doctors, saying they are plastic surgery trained, you know, which is just quite clearly not the case. And one of the things I think is that we've got a bad enough issue in the UK with what I call the cowboy sector, all sorts of non-medical people, you know, any old person doing aesthetics and making out that they are experts. So, you know, we've got that cohort of people to deal with, as it were. But now it seems like we're almost getting another group that we're having to deal with. So, tell me what you think. How do you see that problem? How do you think that came about? Is that our fault? Did we maybe...
It's a difficult one. I think it's interesting because I think you see this a lot with your trainees and you as well, Nav, that there is, you know, they are a bit demoralised and see aesthetics as sort of this glitzy career of an easy life.
And so are ophthalmology trainees similarly demoralised as I think plastics are?
I think there's a mix. I like presumably the same as the plastics trainees. We still have, you know, the high flyers who you look back on your own career and you think they're on that trajectory of, you know, a similar sort of process. But I also think there are people coming in at the ST1, 2 end who feel it's a very long road ahead. The conditions probably are not as good as they were 10 years ago. The rotas are a little bit less well staffed. The number of patients is higher. The amount of admin's worse. The pay hasn't kept up with inflation. So I think for those reasons, they look for areas that they can do instead. And I think naturally a plastic surgical trainee or an ophthalmic trainee who's interested in, you know, microsurgery and using their hands sees aesthetics as a natural option. And I don't see that as a problem as long as it's done properly and with full disclosure about their level of expertise. Clearly, if they're saying they're a board certified plastic surgeon, there's a problem.
It's not necessarily, but they're saying they are plastic surgery trained. It's all the way that there are different ways of wording things.
But it's
interesting. People are, they can be very, they can bend the truth, can't they, with this? And of course, the general public aren't going to really do their due diligence on it a lot of the time.
Because I think I agree with you. All those things that are just not quite as good as they used to be when we were training. And it's very easy for us to go back in my day. It was so much better or whatever. But I think definitely it is harder for the guys today. But it's also, I've been a consultant now for 15 years. I think it's 15 years and a bit, a couple of days, I think. I look back on my training and it was like a blip, having been a consultant for 15 years, my training was 6 years in specialty plastic surgical training, as it were. And it wasn't that long a road ahead. It's everything looks like it's so far away when you're younger.
Yeah.
And I'm sure my kids see the same thing. Yeah. It's like, their next term at school is probably like a lifetime to them when they're that age. And so I think there's an element of that. So it's trying to get our, successors to appreciate that, I think, is really important, because I think the main part of the specialty is going to suffer if a whole lot of people go off and do aesthetics.
Exactly.
And unfortunately, the NHS, it trains, but it doesn't have an incentive to train, and it's so busy trying to keep up with the backlog and the waiting lists and whatever that training almost falls by the wayside. So do you think, going off on a slight tangent but similar theme, do you think the private sector, which we all work in, do you think we should take a little bit of responsibility for training not just aesthetics but also some of the some of the I don't know, in plastics it's the reconstructive side, for example, so VR. So do you think there's a place for you to train people in your private practice?
So that's a great question.
Happening already.
VR is a little bit different because it's so subspecialist. But for cataracts, I think it was either a year or two ago, actually now more than half of cataracts done in the UK are not done in the NHS. Yeah. So they're done either privately or independent providers. Yeah. And that was
very successful, isn't it?
Yeah, I think there's been mixed success, and I think how it's been delivered has been, very good for a lot of patients. It's been slightly less beneficial for some patients, and clearly there are some companies that do it very well and others less well. One of the challenges has been, those companies have cherry picked a lot of the easier cataracts off, and now actually they are starting to train NHS trainees. So they actually have arrangements with the College of Ophthalmologists, and our president is quite encouraging of that, where you'd be part of a hospital and you'd say, look, instead of your cataract list being in this hospital, you're just going to go to this place and you'll do your list there. And of course, then you get to high volume cases with high volume cataract surgeons. So I see that as a way forward. And certainly for high volume things like cataract surgery, it's great. It's a bit less relevant for retina because there's a little bit less of it around, and it is technically, a bit more demanding.
And it probably does need, a proper setup for training, I'm guessing.
Yeah. And I, I have a fellow and trainees who train, but I think it'd be hard to do that side of things outside the NHS.
Yeah. And
I think, in aesthetics, there's a few initiatives I'm involved in. Obviously, there's the Royal Society of Medicine, as I'm sure you both know, have just recognised aesthetics as a specialty. Yeah. So that's a real landmark event, a historical event. But the slight issue is that that's great, but there's still no set training programme for aesthetics. So whilst it has been recognised as a specialty, I still feel we're a long way off from having a proper training programme in aesthetics. And it's really important because, things do go wrong. There are complications with fill. Obviously, we've spoken about visual loss. But, I've had patients that have fainted and had a vasovagal on the table. I've had patients that have had an allergic reaction to Hylays. And being a consultant surgeon helps. You don't have to be at that level, but you have to have some confidence and experience in managing it. Exactly. But what's good as well is the Aesthetics Journal at CCR next week. They're doing a mentorship scheme, which I'm involved in. So it's a speed dating. I think you're involved in that too. I think we're both doing it. So it's going to be quite fun. So, there is an opportunity to mentor people in aesthetics because there isn't such a robust training program like there is in ophthalmology and plastic surgery and all the other specialties. So I think there are opportunities out there, but it's still
because I think we are
official.
I think the NHS is struggling, as we keep hearing about at the moment, and it's almost it feels like a good way to sustain a good private practice almost, because I want someone to take over and look after my patients after I'm gone. So it makes sense for me to train someone to do that. And, with Prof. Collins.
Yeah, exactly. I was really open. I said I wanted to learn to do blepharoplasty. And I really went out of my way to learn. I went to all his lists. They're mainly in the evening. Any free session I had, we had admin sessions in ophthalmology. I don't know if you get that in plastics, but we had admin in training. I'd observe lists. So you have to go out your way to learn.
Yeah.
But the opportunities are there. And like you said, it's great to have a mentor.
And I'm hoping, we're starting to get BARPS mentees. There's a thing called BARPS mentorship scheme. Yeah. We get people coming through post-CCT for 3 months. The deaneries are starting to send people, as we were saying earlier, before we went on camera. Yeah. I think that's a great thing, and I wish we can get more and more of that, because I think there's and everyone who does come here and spend time training actually really enjoys it and learns loads, and I think it does get them started on hopefully the proper path rather than the cowboy path, and with a bit of luck that will make training in the NHS a little bit more attractive.
Exactly. Yeah.
I think it's progressive in plastics. I mean, that scheme's been around for a while, hasn't it? And I think the amount of ophthalmology that's moved into the private sector, the sort of the classic area for us is refractive surgery. So people having laser eye surgery to get out of glasses. Yeah. We have no training in that really as ophthalmologists, or very little as part of our 7 years.
Are you examined on it, by the way? Because there's lots of stuff that we're examined on as plastic surgeons, but we're never trained on.
You're examined on elements of it, but if you want to ultimately do it, you have to do a separate examination. Yeah. Oh, really? Okay. But considering ophthalmology training it was 7 years, it's now come to 6 years. I think a small period of time where trainees maybe went to a successful private clinic. Yes, and I should just say I don't do any of that sort of work, but there are some really brilliant clinics there where you learn a phenomenal amount, and I think that would actually be something that trainees would find really interesting.
Really motivating and encouraging.
Do you guys have post-CCT fellowships in ophthalmology? I'm guessing you must do for oculoplastics or VR or this or that or the other.
James, you did too.
Yeah, so I did a couple. Which you just have to do for retina, but and that makes it a long time. If you do 7 years of training for us, you do a high degree, you do fellowships, whereas in the States you do 4 years of residency and maybe 1 or 2 years of retina fellowship. So we are quite long in the UK.
And are you better than them when you come out of the system? Is that how it went?
Compared to America,
we
we get more surgical training. I remember being at a conference in America and just chatting to the trainees there, and I told them my cataract numbers. This was about 10 years ago. I said, I've done about 800, and I hadn't finished training yet at that point. They'd only done 150.
Okay,
So you're more surgical experience after the residency equivalent, but they have intense surgical fellowships.
Particularly in retina. That happens in plastics as well.
They'll be in theatre every day potentially, which fellows in this country tend not to have as much
acceleration, isn't it?
And who knows if that's a good or a bad thing? I don't know, but I think at the end we all come out probably pretty even, I'd say.
So I didn't ask the same question that you kindly answered earlier on about, so if you go back to that poor trauma SHO in Mary's in the middle of the night, staring across the patient,
what would I say?
What would you say to him?
I think the key is to just have a varied career. Yeah, I think that's the key to longevity actually in medicine, because we've been in the specialties for a long time. We've seen who's enjoyed it of our superiors and who's maybe not enjoyed it as much, and I think the people who've enjoyed it the most have been those with extra interest, whether or not that's setting up a clinic or having a completely different research interest. And for me, the period of research opened all the doors for for me, I think. That 2 years, I met a lot of people in industry. I looked at things with a totally different critical mindset, and I met a lot of, really impressive surgeons during that time. And I think that was the eye opener for me to get involved in these different areas. Whereas I think if you just get on the training treadmill and you do your rotations and you sign off and then you get your consultant job and you sort of then think, oh, crikey, I've kind of missed the boat,
Yeah, absolutely.
And I think you've got to get into that in the early times.
I couldn't agree more, actually. I kind of call it wearing the different hats.
Yeah.
And I carry on wearing different hats, I won't go on about them. But I think, the looking at my contemporary trainees, there are some that were just the blinkered fast track to consultant job. And you look at them now, and I can almost see that cohort as being the more burnt out, or bitter and twisted, or bored, or resentful, or whatever. Whereas the ones who are still having fun, I think, are the ones who've done different things, like research, or go into a little bit of.
And they've taken the risk, of course. They're the ones who've taken longer to do it, or they might take a financial risk.
Scenic route,
exactly.
And so charity, or
it's not the easy. It's not the easy option,
but
I think
it's a much more fun route. I think definitely,
it's the way forward.
I think we're saying the same thing, and that's sort of what I meant when I said just go for it.
Yeah.
So if you've got something in your mind that you want to do, just do it in training. Don't be scared about what other people and your seniors will think and how it will affect your chances of getting a job, because you'll get one in the end.
I think great. And then finally, just before we wind up, first of all, thank you very much both for coming in. It's been really nice talking to both of you. So thanks for taking the time out. Thanks for coming down.
Pleasure.
And so, is there anything you wanted to say? Actually, if you wanted to get a plug in or whatever, anything. Have I missed something that you're desperate to talk about? I don't know, but. Speak
What's
now.
our plug? Got the whole eye covered?
I think you got it. Yeah, exactly.
I think we've covered most of the bases.
I think we've covered it.
No,
it's
thank
really
you.
fun to chat to you. Thanks so much for having
It's been a nice
It's
chat.
our first duo.
Is it?
Podcast,
Cool.
duo anything,
it's
so
my
thanks.
first. Yeah, same thing here as well. Let's see. I'll try and think of other power couples I can invite over as well. So no, thank you very much. And come back, I'm sure, at some point, maybe towards. I always think we should do this again, maybe towards the end of our careers or something.
Oh gosh,
Can you imagine what that would be like? Can you imagine? I don't know. Let's see. Think about it.
Well, 40 years. 40 more years of blepharoplasty.
But thank you for coming. Thank you for watching, listening. We'll try and put some links and things to the clinic, to your practices in the description or whatever of the podcast. And Instagram links and so forth as well. So please follow and catch us for the next one. Thank you very much.